Yeah. Hello, everybody. According to my watch here, I've got 1 o'clock Eastern time, which means it is time for us to do the RHC Billing 101 with Amanda Dennison. I think most of you probably know her by now. She's on the board at the National Association of Rural Health Clinics. She does presentations all the time for RHCs, and they're fantastic. And she's with Blue and Company. And, if you're in Kentucky, I'm sure you know her. I think we're going to get her out to Kansas. And so folks in Kansas, you're going to get to see her pretty soon as well. So Amanda, I will get out of your way and let you present.
And, all right, sounds good. Absolutely. Well, thanks for having me, Mark. I know that these presentations are always incredibly helpful for people. So as Mark said, I am with Blue and Company. I've been at Blue for about 12 years now. For the past 9, I've worked almost exclusively with RHCs. And so in my mind, that's still relatively new to the RHC space, considering some of the people like Patty and Charles and Mark himself who have been in this space for a while. So I tell people all the time, I'm still learning things every single day. So hopefully you can find some solidarity in that, in knowing that you are not alone. RHC billing is incredibly difficult. And so hopefully we can provide some help to you all there. Just a quick introduction to Blue and Company. So Blue was founded back in 1970. We currently do have 10 offices in 3 states, so in Kentucky, Indiana, and Ohio. I'm based out of our Louisville, Kentucky office, which is one of 3 offices that we have that is solely dedicated to helping healthcare clients. And so we help a variety of different healthcare facilities, hospitals, both big and small, and really small. And then we also help, obviously, rural health clinics, FQHCs, private physician offices, dental offices, mental health practices. So we kind of have, expanded our services as healthcare has continued to change. Obviously, as a CPA firm, we do provide a lot of services that are just more sort of accounting in nature, but I am not an accountant. And so again, our 3 offices that do healthcare, we do have a lot of niche services as well outside of just the typical accounting space. So we do revenue cycle management and reimbursement opportunities. We've done a lot of margin improvement plans lately for people, starting to look at sort of physician reimbursement and some of those types of things. And then I myself work in anything in the RHC space. So if you have any questions, my email is going to be at the end of this slide deck, so feel free to reach out. I know you all are not here to learn about Blue, so we will jump right in and start talking about RHC Billing 101. So a couple of disclaimers before we get started today. I generally put these at the beginning of every presentation, even though, I'm sure you've seen it before, okay? So the information from this webinar is current as of this morning when I sent it over to Mark, right before he posted it on Facebook, okay? You guys work in healthcare and you know that regulations can change seemingly by the minute, sometimes depending on where you're located. So again, I might present today and there might be something that happens tomorrow. We hope not, but just in case, make sure you do your due diligence and make sure that any resources or references in this presentation haven't been replaced with any more current guidance, okay? Today, we are going to stick to talking about just regular Medicare from a billing standpoint, traditional Medicare only. I will briefly touch on some Medicare Advantage issues and things to be aware of. From a Medicaid standpoint, we are not going to talk about Medicaid at all, just because a lot of states, while they may be very similar, there are a lot of different nuances from state to state, whether it be different eligible providers for an RHC, whether it be different services, and just different requirements of that nature. So if you do have questions about Medicaid billing for an RHC in your state, reach out to any of us, to Mark and Danny, myself, Patty, Charles, any of us that work in the RHC space. If we can help you, we'll help you. If not, we'll connect you to the right person within your state that can help you to get some additional resources, okay? So these are the things that we're going to cover today, okay? There are 2 more billing presentations after the one that I'm doing today. So if you don't see a topic listed here that you were hoping I was going to cover, that's because it's going to be covered in one of the other 2 sessions, either with Patty on Thursday or Charles, I believe, a week from today, okay? So again, this is what we're going to try and stick to today. If you have questions, please hold those questions until the end, just so we don't get off track. Also, if some of your questions are related to something that's going to be covered in one of those future topics, in the interest of time, I will defer to those presenters when you all do that presentation later on in the week, just so that we can cover the topic specific to today. Okay. All right. So we're going to start with the definition of an RHC visit. Okay. And this is the typical standard definition that we're all used to. However, it has since been expanded. Okay, so an RHC visit, and this is straight from the Medicare Benefits Policy Manual. I didn't make this up. It comes straight from CMS. Okay, a rural health clinic visit is a medically necessary medical or mental health visit or a qualified preventive health visit. It must be face-to-face and one-on-one between the patient and one of the provider types you see listed here. So a physician, an NP, a PA, a CNM, a CP, or an LCSW. Okay, now, some of that is expanding in terms of the providers that are allowed to provide RHC billable services, okay, and we'll talk about that here in just a few minutes. There's this word, however, that was added in January of 2022, okay, and that was to cover these mental health telehealth visits that we're now able to provide in the RHC space, okay? So if you go out to the Benefits Policy Manual, you're gonna see some text in red that CMS added as of January 2022. So all this fluffy, flowery language is basically just to tell you that you can also provide a mental health telehealth visit, and that face-to-face element of that, at least for now, is waived, okay? So what is not considered a rural health clinic encounter, okay? So these are a few examples that CMS gives of things that are not considered an encounter, okay? So visits only for medication refills, okay? So if we're not assessing the patient, they're not having any issues that we're needing to address, we don't necessarily need to see them just so that we can refill their medications, okay? Visits only for lab results. Now, the sort of caveat that I give here is if you have a patient who has an abnormal lab result and you need to have them come back into the office because that lab result now changes their medication, something about their course of treatment or some sort of therapy that they're going through, that would be appropriate to bring that patient in, assess them, set a new course of treatment, and you'd get an E&M level visit out of that, okay? But just for normal lab results, it's not medically necessary for us to communicate those during an office visit, okay? Another example is visits only for injections. So allergy injections is the example here. It could be a B12 injection, testosterone injection. Those are generally things that don't have to be given by a provider. They can be given by your clinical staff. So again, not medically necessary for a provider to be involved in that visit. Suture removal or dressing change without an additional face-to-face visit, and then visits that were generally billed using that 99211 nursing visit, okay? Now, a lot of times I have people say, okay, well, if it's not an RHC encounter, that means it's not billable. And that's not true. It means that on their own, they don't qualify as an RHC visit, okay? And we'll talk a little bit about some of the things and services that do qualify as a visit. But again, the definition we just looked at, it means that these services here don't meet one of those qualifications, okay? So let's talk about your RHC eligible provider types, okay, for Medicare, okay? Again, so these are the provider types that are considered to be billable RHC providers, okay? So a physician, whether that's an MD or a DO, a nurse practitioner, a physician assistant, certified nurse midwife, certified psychologist, licensed clinical social worker. We talked about those. It's written directly into the definition of an RHC visit. There are two additional provider types that Medicare is going to start reimbursing as a billable provider in the RHC space beginning January 1 of 2024, okay? And that's a licensed marriage and family therapist or a licensed mental health counselor. Now, it could be that your state doesn't call it a licensed mental health counselor. It might be a licensed professional counselor. So that's going to be driven based off of state definition. So don't think that because it's not an LMHC that it doesn't qualify. There are state-specific definitions for what's going to qualify there, okay? Now, again, do remember that your state Medicaid might have far more provider types that are considered billable in the RHC space. This is just specific to regular Medicare right here, okay? Now, undoubtedly, when we start talking about providers, the question will eventually come up from someone who already provides dental services in their RHC or in their clinic to say, okay, well, what about dentists, okay? So CMS does specifically have a section of the benefit policy manual that addresses dentists, podiatrists, optometrists, and chiropractors, okay? So you'll see here what CMS says, that those are defined as physicians according to Medicare statute, and qualified services by a physician are billable visits in the RHC, okay? So what does that mean? It means that an RHC can bill for face-to-face medically necessary services provided by one of those provider types, okay? So long as the service that's furnished is a qualifying visit, okay? It does have to be within the scope of their practice, so their state practice, and then it cannot be excluded from coverage. So that relates to certain services that chiropractors generally provide. There are certain services that are excluded from coverage, okay? Now, where you have to be careful with these provider types, okay? And again, this is not anything that I am making up. It comes straight from the benefits policy manual. RHCs are required to primarily provide primary health care, okay? Those types of providers, a dentist, podiatrist, optometrist, and chiropractor, are not considered primary care providers, okay? So what that means is they cannot serve as the physician medical director for your RHC. They also don't qualify to be the physician or non-physician practitioner that must be available at all times the clinic is open, right? So in an RHC, there has to be a provider on site during all RHC hours. A dentist, podiatrist, optometrist, chiropractor is not going to qualify for that, okay? Now, expanding on that further, okay, what about our other specialist providers? Because it's a common misconception when I first start talking with clients about, you know, considering the RHC, they're like, well, we're gonna have to move all of our specialists out to a new space. That's not necessarily true, okay? Specialists can provide billable services in an RHC, right? You could have a neurologist, a cardiologist, you could have a mid-level provider, a nurse practitioner, a PA who works in those specialties. Okay, so think of all of your ologists that you could have. They can provide billable services in the RHC space, okay? You can employ them at the RHC, or the parent hospital can employ them. You can also contract with them, so they can be a visiting specialist that just comes in from time to time, maybe one day a week, to provide services, and your RHC contracts with those specialists, bills them as RHC providers, okay? There's a lot more logistics involved there, and things from a contractual standpoint you will need to make sure and address. We're just talking from a billing standpoint, you can bill them as a rural health clinic provider. A couple of things to remember with that though, okay? Again, RHCs must be primarily engaged in providing primary healthcare services. This is a little bit of a gray area as to how primary care is defined, and we're not going to get into that today because that's more of like a regulatory language or some clarification, some guidance, but there is a gray area there, okay? So be careful if you have a lot of mental health specialists, maybe just consider that 51-49% mix that you have. And then lastly, if you have a bunch of specialists that are in your RHC, if they're seeing both their primary care provider and one of your specialists who's not a mental health specialist, okay, on the same day, you're only going to have one all-inclusive rate paid, okay? You're going to put both services on the claim. However, only one all-inclusive rate is going to get paid, okay? So just be aware of that. Let's talk about your claim form that you're going to use to bill your RHC services, okay? So RHC services are billed on a UBO4 if you're submitting a paper claim. The electronic format for that is the 837I, okay? This gets confusing for people because RHCs do provide what we consider to be professional services, okay? But an RHC is considered to be an institution. It is its own facility similar to how a hospital is its own facility, right? We file an 855A, which is an institutional enrollment to become an RHC. And it specifically aligns this out in the claims processing manual to say that RHCs are institutional claims and all professional services in the RHC benefit are paid through the all-inclusive rate system for each patient encounter or visit, okay? So that can get a little bit confusing. So just remember, RHCs are institutional providers. As such, they do bill claims to Part A, but are paid by the Part B benefit. Anybody confused? I know that can be very confusing. Again, UBO4 is the correct claim format for your RHC services. Okay. These do have a specific type of bill, sort of a series that they use. Those are going to fall under the 71X codes. Technically speaking, this is a 4-digit number. The leading 0, CMS just ignores. So 71X, and that X is going to identify the different types of bill that you can have in an RHC, okay? So a 711 is going to be your original claim. Okay, that's going to probably be the majority of what you're sending out is just your original claim with all of the services you provided during that encounter. Now, if you have a non-payment or a 0 claim, you may have this if something is not covered by Medicare, but you have a patient who still wants the service provided. You provide them with an ABN prior to the service. They sign it saying that they're going to be financially responsible. You submit that claim to Medicare for a denial so it can fall to patient responsibility. That's when you're going to use a 710 bill type, okay? Or one of the examples of when you might use that. An adjustment claim is bill type 717. The two most common times that I see this used are with our injectable medications. Getting those units right sometimes can be a little bit confusing from a coding standpoint. So we may have to submit a 717 to fix that if we got the wrong units on there. 717 is also an option for our incident to services, which we will talk a little bit more about towards the end of this presentation. Okay. And then 718 is a canceled claim. Let's say you have a duplicate claim and you accidentally, put 2 in for the exact same thing. 718 would be what you'd use to cancel one of those claims. Okay. All of this guidance about the bill types and sort of the different claims requirements is going to be in the claims processing manual. That section 50 there has all these different requirements for each field locator. Okay. So the field locator 4 is where this all comes from. RHC revenue codes. So we talked about our type of bill that goes in the top right-hand corner of our UB. Now we'll talk about these revenue codes that we have to have attached to every service that we report on the RHC claim, okay? So these 52X codes are the ones specific to both RHCs and FQHCs, but we're obviously only gonna talk about RHCs here today. So 521 is probably gonna be your most commonly used revenue code. It's just a clinic visit by one of your patients into the RHC, okay? Your RHC providers can do home visits for your patients, okay? If they do that, it's going to be under a revenue code 522. There are specific home visit CPT codes that would be associated to that. 524 and 525 are gonna be your nursing facility codes, okay? And the type of stay that the patient is in is going to help drive which of those 2 revenue codes you use. Okay, so 524 is for a Part A covered stay in a nursing facility. 525 is a non-Part A stay, okay? 527 is a unique one because it's one of the only times that you might have an RN or an LPN that would be considered a billable provider for an RHC service from a Medicare standpoint. And that's because 527 is for visiting nursing services to a member's home, okay? The catch is that they do have to be in a home health shortage area, okay, if you are providing those services. Someone asked, I think last year when we did this presentation, how you know if you're in a home health shortage area. It is not listed out on the HRSA website the same way that your primary care shortage areas are or anything like that. You should be able to contact your state, I believe, and your state should be able to let you know if you are located in a home health shortage area, okay? But there's nowhere that you're necessarily gonna be able to look it up in a database. 528 is a visit by an RHC provider to another non-RHC site. And they specifically give the example here of the scene of an accident. And the reason they give that example is because they don't want this to be misunderstood to say that the patient is in some other type of facility and our RHC providers go see that patient and that qualifies as an RHC visit, okay? That's not the case. If it has other rules that Medicare has already outlined for that specific facility type, that's not what 528 is intended to be used for, okay? So again, scene of an accident is the example there, so just kind of keep that in mind. And then revenue code 900, this is the only one that's not a 52X code, but 900 is for all our mental health visits, and that's both in person and via telehealth. And we're not gonna cover telehealth today. I believe Patty is covering that later this week, so just be aware of that. Okay, so these are some other common revenue codes that you might see used in the RHC space, okay? There are by no means like just a dead set list of codes, okay? There's a whole list of Medicare revenue codes out there that you can look up. The Novitas website actually has them organized pretty well. So if you go out there and just Google revenue codes, there's a whole list of them. But these are some of the more common ones I see used in the RHC space, okay? So revenue code 250 is your pharmacy codes, okay? Those are gonna be drugs that don't have a detailed J code, okay? Venipuncture is under revenue code 300. Your drugs that do have that J code, so a lot of our injectable medications are gonna be under revenue code 636. And then the revenue code 780 is for our telehealth originating site, okay? Originating site is the location of a patient during the telehealth encounter. So again, CMS is basically paying you a fee for hosting the patient in your RHC. They're usually seeing a provider that's physically distant elsewhere, okay? All right, some more RHC claim details to be aware of here, okay? I'm sure I have like crossed over the rule of how many words you're supposed to have on a slide, but there's a lot of things to try and remember when it comes to including everything you need to on an RHC claim, okay? So we've kind of already talked about this, but RHCs are required to line item detail code for all services provided during a patient encounter, okay? So that's gonna be your RHC services, any incident to services provided, any professional components of certain services, and then it could be, procedures, anything else that you did during the patient encounter that is billable on your RHC claim, okay? All of those services are reported with either actual charges for the services or a penny. The only exception to what cannot be reported with a penny is what's going to be on your qualifying visit line, and we'll define the qualifying visit line here in just a second, okay? Whether or not you report your services with actual charges or a penny is largely a decision based on two things, really, okay? Preference and the functionality of your billing system, okay? I have a preference for one versus the other, but my preference does not matter. Each of you are going to have to make that determination for yourself as to which is the best option here, okay? So CMS accepts either one. Now, regardless of how you report those charges, your total charge for the services based on the actual charges is going to roll up, okay, that roll up to the qualifying visit line or the CG modifier line, okay? So if you report with a penny or you report with actual charges, what is on that one line should be relatively the same, okay? The only exception to this roll-up requirement is for qualifying preventive health services, okay? And I believe Charles is going to cover preventive health services next week. If it's a qualifying preventive health service, we don't roll those charges because coinsurance and deductible are waived for those, and the payment for those is a little bit different than just your like E&M office visit, okay? And Charles will cover that next week. Your total charges are still going to be reported on that 0001 line that's at the bottom of your claim where you put all your charges, okay? CMS doesn't use that line item to adjudicate payment for anything, okay? So just be aware of that. It's still going to be reported there, but CMS doesn't use that as any sort of like indicator. Now let's talk about this qualifying visit line that we've been talking about, okay? So every RHC claim must have a qualifying visit line, okay? The definition of that qualifying visit line, okay, it serves to identify the primary reason for the patient encounter on a given date of service. That could be an E&M office visit. It could be a procedure. It could be a preventive health visit, okay? Whatever the primary reason is that the patient is showing up to your RHC that day is what you're going to put as your qualifying visit line, okay? The qualifying visit is likely listed, the CPT code for it is likely listed on the qualifying visit list, okay? So we have a qualifying visit line, we have a qualifying visit list. The qualifying visit list is something that was developed by CMS back in 2016 when the CG modifier was first put into existence for RHCs, okay? So the whole goal of this qualifying visit list, and there is a link on here, so when you get these slides, you'll be able to go to that link and it'll take you to the current qualifying visit list for RHCs, okay? So when they first put the qualifying visit list out in 2016, it only had about 30 codes on it, okay? And they're the codes you'll see listed in black. And those were the codes that CMS said, these are the only codes that qualify for standalone reimbursement. They're the only things that qualify as an RHC encounter. And so when they opened it up for comment, lots of RHCs started writing in to say, hey, according to how you define a visit, okay, so one of those very first slides that we looked at, we have a ton of procedure-only codes that we feel should be added to this list. So that's what you're gonna see listed in red if you go to that link, okay? Or all these different procedure codes that CMS started adding as people were writing in, okay? So they did add this line here. It is not an all-inclusive list of standalone billable visits for RHCs. They basically stopped updating this list on August 1st of 2016 because they kind of realized there is no way we can fully capture every single one of the codes that could possibly stand for RHC reimbursement, okay? So even though there may not be a CPT code listed on that qualifying visit list, it doesn't necessarily mean it doesn't qualify for RHC reimbursement, but this list is a really good comprehensive list to get you started in looking at what services are billable for an RHC, okay? So just keep in mind, it's been 7 years since it's been updated. Any changes to the CPT code sets, okay, so we had some this year for like those home visit codes and the rest home codes, things of that nature. It does not take into account any of those changes, okay? All right. Now, the CG modifier. So the CG modifier and the qualifying visit line are kind of married, okay? The CG modifier identifies the qualifying visit for a date of service, okay? And that's why we have to make sure that it is on the claim. Your specific system may not put it as the top line, and that is a common question that I get from people is, well, what if it's not at the very top? What it's not, you know, it's not first on my list of, you know, reported codes? That's okay. Some systems put them in order according to revenue code, so it's not a huge deal as long as that CG modifier is attached to your qualifying visit, okay? It also tells Medicare what line item they need to use to calculate any applicable coinsurance and deductible for the patient, okay? And coinsurance and deductible is something that, excuse me, that Patty's gonna cover, I believe, on Thursday, okay? But again, coinsurance is not based on your all-inclusive rate, so it's not based on your payment, it's based on the actual charges that are reported on that line. So that's why the CG modifier is important. Generally speaking, there is only one CG modifier per RHC claim. However, there are a few exceptions to that rule that I want to make sure we cover. Okay, so this is a lot of words. This is the guidance directly from CMS regarding multiple providers and multiple visits on the same day. Okay, so this is from the claims processing manual. And so the first part here says, except as noted below. And so those are the exceptions that we're going to talk about. Encounters with more than one RHC provider on the same day or multiple encounters with the same RHC provider are going to constitute a single RHC visit and they're payable as one visit. So that's this whole idea that we're paid on the basis of an encounter, okay? And it applies regardless of length or complexity of the visit, regardless of the number or type of providers seen, whether the second visit is scheduled or unscheduled, and whether the first visit is related or unrelated to the subsequent visit, okay? So you're gonna see why there's some exceptions here in just a minute. And then lastly, this includes situations here, and we kind of talked about this already when we talked about having a primary care visit with a specialist visit, okay? This would include situations where an RHC patient has a medically necessary face-to-face visit with an RHC provider and then sees another RHC provider, including a specialist, for further evaluation of the same condition or a different condition on the same day. Okay, so that's directly what CMS says. And then here are the exceptions that they give us to this rule. So any time you see one of these exceptions, this is going to mean that you're going to have more than one CG modifier on the claim. Okay, so the first one is what we call subsequent illness or injury. Okay, so the example that I always give here is that a patient came in the morning. They had a follow-up with their primary care provider for their hypertension. They went home, they were working outside in their yard, they fell and they cut their leg, okay? They had to come back to the RHC on the same day and whether they saw the same provider or a different provider, it doesn't matter in this instance. They had separate diagnosis and treatment. Okay, that's the key there. They had separate diagnosis and treatment. Okay. This section in bold here is really important because we miss this a lot in the RHC space. I can't tell you the number of RHC claims that I have reviewed that have had a modifier 25 or 59 used inappropriately on them. Okay. In this situation only, the RHC would use either 59 or 25 to attest that the conditions being treated qualify as 2 billable visits. Okay. So if you come from just the physician office world and that's like your background as a biller or a coder, you use 59 and 25 all the time on claims, okay? In the RHC space, those modifiers mean something completely different than they do for just the private physician office space, okay? We should very rarely be using 25 and 59, and it's because they should only be used for these subsequent illness or injury examples, okay? From time to time, I have a client who says, well, I put that modifier on there and Medicare paid for it. Just because you got paid for something doesn't mean you were supposed to get paid for something, okay? And eventually Medicare will figure it out and you will have to pay back that money. So make sure that we're using these appropriately, okay? The other 2 examples that are exceptions for this multiple visits on the same day are going to be when you have a medical visit and a mental health visit on the same day. I do see this happening increasingly as RHCs are looking to see how they can integrate mental health into their primary care RHC, okay? So you're gonna have a CG modifier on the medical visit and a CG modifier on the mental health visit, okay? And the third example that CMS gives as this exception to the rule is if there was a medical, a mental health, and the IPPE taking place all on the same day. Okay, so you could have up to 3 billable services on that day. Now the IPPE does not require a CG modifier except from certain MACs. So just be aware of that, okay? Now there's a link here to the CMS RHC reporting requirements FAQ. We've been told that this is going to be going away, but I checked yesterday and it was still there. So I would highly suggest going out to this link and printing and saving it somewhere because it is a really good FAQ to help you understand when you do and do not need a CG modifier, what the different exceptions are and things of that nature, okay? One of the questions it addresses here that's actually very common is when you have an E&M visit and an annual wellness visit on the same day and how you assign the CG modifier in that instance, okay? All right, so we've talked about all these different claim requirements and what you would need on the claim. Now let's cover what your actual payment looks like from Medicare, okay? So you'll hear me say it. I've said it already on this webinar a handful of times. If you've ever been in an RHC billing webinar before, you have heard us consultants say RHCs are reimbursed their all-inclusive rate, okay? And that's only 78.4% correct. So RHCs actually from Medicare, you receive 80% of your all-inclusive rate, less 2% sequestration taken out by Medicare, okay? So when you do that math, which I'm not a big math person, but when you do that math, you're basically gonna take your all-inclusive rate, multiply it by 78.4%, and that's what you can expect to get paid from Medicare, okay? Now, just remember that Medicare will not start paying on your RHC claims until your patients met their Part B deductible each year, okay? And that continues to just go up. So at the beginning of each year, it is very common to see what we call negative reimbursements. And Patty's gonna cover that fun topic for us, I think, on Thursday, okay? So we're gonna switch gears a little bit here. We've talked about RHC services and how you can bill your RHC claims, but what about non-RHC services, okay? So there are certain things that are classified as a non-RHC service. And basically what that means is that there are certain services the RHC might be providing that are actually beyond the scope of the RHC benefit, or they're not a Medicare benefit, okay? And these are considered non-RHC services, okay? There are specific sections in both the claims processing manual and the benefit policy manual that cover non-RHC services, okay? It is a very common misconception when I say non-RHC that people assume that means non-payable, okay? Non-RHC does not mean non-payable. It simply means that the payment mechanism for those non-RHC services is outside the structure for your RHC reimbursement, okay? In other words, it's paid outside of your all-inclusive rate, okay? And because of that, it has different billing requirements, okay? So because it's a non-RHC service, we also have to remember, and this is like Mark's area of expertise here, that all costs associated with those non-RHC services should be removed from your RHC cost report, okay? So that's the space, the equipment, supplies, facility, any overhead, your personnel salaries for those non-RHC services would get carved out, okay? So these are some of the examples that CMS gives for those non-RHC services. Probably the most common two for most RHCs are these technical components of RHC services, okay? So the technical components of x-rays and EKGs, and then your lab services, okay? So remember, there are 6 labs that every RHC has to have the ability to provide, okay? They're still considered a non-RHC service, even though you have to have the ability to provide it, okay? Just keep that in mind. I do see some RHCs that provide DME, okay? That's another common one that I see. Other than that, there aren't a whole lot of these that I'm seeing just in the RHC space, okay? Some of these are more hospital or certain specialty providers that I see providing these, okay? Now, how are we paid for those non-RHC services, okay? Well, our non-RHC services get billed differently depending on the type of RHC that you are, okay? So for all of your RHC services, which we've already talked about, you bill those the same whether you are an independent RHC or a provider-based RHC. No difference in how you would bill. The difference in how you bill comes in here with these non-RHC services, okay? So independent RHCs are going to bill Medicare Part B using your RHC PTAN number, okay? Provider-based RHCs also bill Part B for those services, but under the parent hospital, okay? So it's going to look to Medicare as if they walked into the hospital. Now, you can have a different RHC fee schedule that's set up so that those patients aren't getting charged hospital rates when they had the service done at the RHC. That's not a requirement, but that is something that you can do because I know that's a concern for some people in the provider-based space, okay? Now, the payment for those non-RHC services, again, differs depending on the type of RHC that you are, okay? So critical access hospitals or provider-based RHCs that are provider-based to a critical access hospital are going to receive cost-based reimbursement for those non-RHC services, okay? PPS hospitals, so provider-based rural health clinics to a PPS hospital, and then our independent rural health clinics are going to be reimbursed on some sort of fee schedule. So if it's a lab service, it's according to the lab fee schedule. If it's a technical component, it's according to that radiology schedule that they have out there. Both of those things are on the CMS website under all of their different fee schedules, so it shouldn't be a surprise to you. You can go out there and look those rates up, okay? So this is a really helpful chart, and I hope you've all seen this before. It does get used frequently in some way, shape, or form by, I think, all of us, just because it's a very good depiction of how you bill depending on the type of service that's being provided and depending on the type of RHC that you are, okay? So it's pretty much a pictorial way of looking about what we just talked about, okay? So like I just said, those encounters for RHC services are billed to Medicare Part A on a UB under your RHC PTAN number for RHC services. That's the same for everybody. Those CLIA labs in the RHC, okay, as well as those technical components, those are going to be billed and reimbursed differently depending on the type of RHC that you are, okay? And some of those details are here. Any professional services, so if you have RHC providers that round on patients in the hospital, services that take place in the hospital are not billed under your RHC, okay? Those are billed according to your hospital rules, usually under some physician group. Okay, so those are not going to be billed under the RHC. Just keep that in mind. All right, now we're going to talk about a little bit of like the dirty word, if you will, in the RHC space, and that's incident to services. Okay, so we all provide incident to services more than likely, and those are basically services and supplies that are integral but incidental to your RHC provider services. Okay, generally they're going to be services that are done by your clinical staff. Okay, they are done under the physician's direct supervision unless there is some, there are a few things that can be done under general supervision. It is included in your RHC payment, and they're generally services provided in an outpatient clinic. Okay, now all your services and supplies should result from the patient's encounter with a provider and done within a medically appropriate time frame. So that communicates to you that these incident to services may not always be taking place on the same date of service as their visit with a provider. Okay, so we're going to look at that here in a second. One of the most common examples here is for allergy injections. Okay, and really injections of any kind where they might be done in a series where the patient comes back every week. They don't necessarily see the provider every single time that they come in. Okay, and that's why allergy injections are an easy example to kind of talk about here. Okay. So payment for those incident to services, again, if they're provided in the RHC space, they're included in your RHC all-inclusive rate. And that's whether they are done on the same day as the provider visit or they're done on a different day, okay? Incident to services are pretty easy to capture when they're done on the same day as a provider visit, so the same day as that E&M office visit. They're more difficult to capture when they're done on a different date of service, okay? So if you have an encounter, and this is where this different dates of service comes in, if you have an encounter for only incident to services, on its own, it is not considered a standalone billable visit. So that's why we have to look at options for being able to bill that incident to service, okay? So just remember, the incident to service is still going to generate coinsurance for the patient. It is not going to generate any additional reimbursement from Medicare, okay? So here are two options to consider when addressing these incident to services, okay? And this is incident to services taking place on a different date of service than the provider visit, okay? Your first option is to add the incident to service to a qualifying claim within a medically appropriate time frame, okay? You're gonna hear this called the 30-day rule a lot, which I'm sure you've heard. 30 days is not a hard, fast number, technically speaking. It could be 45 days. That could be considered a medically appropriate time frame. But 30 days is kind of best practices, just because it means at the end of every month, you can go back and look at what incident to services are not attached to a provider visit and figure out how we need to get them onto a claim in order to be billable, okay? Now, this is not a great option because it requires one of two things. It either requires the RHC to hold claims until the end of each month and be able to add all those incident to services onto a qualifying visit, or it requires the RHC to submit an adjusted claim each time those incident to services are rendered. So that's where that type of bill 717 comes in that we were talking about. Neither one of those is a great option, right? It's usually a very manual process because there's not some sort of thing that we can build into our billing system that says, hey, you have these incident to services that need to get added somewhere, right? So it's usually kind of a manual process that can be a headache for a lot of people. When you do have these services taking place on a different date of service, you're still going to use the date of service of the qualifying visit for those incident to services. Okay, so I'm going to use the allergy injection as the example here. You have a patient that came in, let's say on November the 1st, and they had a visit with a provider, okay, a 99213 office visit, and the provider said, I want you to come back every week for the next 4 weeks and get an allergy injection, and then we'll reassess, okay? So every week that they come in, okay, you've got 1 unit that you're having to figure out how to get onto that claim each time that they come back, okay? So you have to figure out which of these options is the best for us, okay? And maybe this option isn't the option that your clinic wants to go with. The other option that you have is, depending on the volume of those incident to services, you can adjust them off to some sort of adjustment code to help you track them, okay? Any of the associated costs would be reported on your cost report, okay? Again, this is different for different clinics. There are some clinics that have a lot of allergy injections that they do. There are some clinics who they just do a handful, and so for them to write them off or find another way for those to be provided at a different clinic they have, that's possible. I fully understand that some of these options are not great options for people, okay? The main thing to remember here is that either way you choose to do this, you are not going to generate additional reimbursement from Medicare, but you are going to increase your patient coinsurance in finding a way to get it onto the claim, okay? So that can often be sort of a decision maker in and of itself for some people, okay? All right, now if you're a more visual person in nature, I'm going to quickly go through some of these claim examples just to sort of visually represent what we have already talked about, okay? So this is a very basic, straightforward E&M office visit only example, okay? So you'll see we've got the 521 revenue code, they had a 99213, the CG modifiers attached, and you've got the charge. Pretty simple, right? There's no rolling up that has to happen. Pretty straightforward. Now, you can also have a procedure only, remember, that qualifies as an RHC encounter. So the difference here, we've still got our 521 revenue code, so we know it happened in the RHC. Here we just have a procedure code instead. We've still got our CG modifier, we've still got our total charges. Pretty simple. Remember that this claim and the claim we just looked at are going to generate the same payment from Medicare, but different coinsurance amounts, okay? Now, what if you had that visit and the procedure take place on the same date of service, okay? When you have that, that's where we start to see this roll up that we were talking about, okay? Again, our 521 revenue codes are the same. Now we have both the 99213 and the procedure. In this instance, the CG modifier, we're saying that the office visit was the primary reason for the patient encounter that day. And 9 times out of 10, in this instance, I see it be the office visit that gets the CG modifier. I'm not going to say it doesn't matter in this case, because you would be reimbursed the same whether you put the CG modifier here or here, but I do see it going on the E&M office visit quite frequently. So here's where we have the roll up starting to happen, okay? We have this $250 that encompasses the $100 charge for the office visit and this $150 charge for the procedure, okay? So that's where we start to see that roll up happen. Now, these next 2 examples are going to be those examples showing you if you report with actual charges versus a penny, just so you can see what that looks like, okay? So here we've got a level 4 visit, we have our injection, and we have the drug. So again, you'll see that 636 revenue code, all right, for our injectable medication that has a different revenue code. They all roll up to this 207. That's an option if you report with actual charges. If you report with just a penny, it looks pretty much the same, with the exception of you have a penny here, and therefore you only have a smaller amount that's being reported on your 0001 line. The reason people like this is because they feel like they're writing off less, and so their AR doesn't look as high. Again, you're not doing anything wrong by reporting it one way or the other. Preference and system capabilities, those are the 2 things to consider. Okay, again, we're not covering preventive services here, but I did want to show you an example of when you have preventive services on the same claim as an E&M visit, okay? So in this instance, we have our 99213 at $150, and we have the annual wellness visit. The charges are not rolled up, obviously, because those preventive services have coinsurance and deductible waived. So that's why we don't want to include it in this line item, okay? So just note on this, with both of those services together, you're only going to get one all-inclusive rate payment. Charles will expand on this a little bit more when he covers preventive services. Okay. This is where we get into the claim examples for all of our exceptions to the rule for when we would have more than one CG modifier, okay? So this is that subsequent illness or injury example where, again, they came in the morning, they went home and cut their leg. They could have come back and it was just an office visit too. This does not have to be a procedure here. That would obviously impact what modifier you used, but just beware, this is one of the only times when we're gonna have that 59 or 25 on the claim, okay? So there would be 2 all-inclusive rate payments made for this claim, okay? This is the medical visit and the mental health visit that are on the same day. This one happens to be an in-person mental health visit. So you have a CG modifier identifying the primary reason for the medical visit, and then you have a second CG modifier identifying the primary reason for the mental health visit, okay? They don't roll up because they're each their own separate service. And then this is that example of if you were to have the IPPE, the medical visit, and a mental health visit. This is kind of a unicorn, to be perfectly honest with you. But again, you can have it. So again, you'll have 2 CG modifiers. You will have the IPPE that does not require a CG modifier. Just know that the IPPE will be paid at 100% of your all-inclusive rate, whereas your other 2 services will receive the reduction of that 78.4%. Okay, so up to 3 payments when you have this scenario. Now this is looking at our like non-RHC service examples, okay? So this is where we have that split billing that starts to happen. So in this instance, the patient had an office visit and they had an EKG, okay? So the professional component of that EKG is still going to go on the RHC claim, okay? So that's that 93010. In the physician office space, a lot of times we see the 93000 used. That's not going to be used in the RHC from a Medicare standpoint, okay? Because we have to split out the professional versus the technical component, okay? I also want to point out the note here at the bottom. The EKG interpretation and report, so the professional component, would only be reported on here if it was done by your RHC providers. If you have an outside company that reads those for you, then it is not going to be billed on your claim unless they are contracted providers of the RHC. Okay. And then this is how the technical component of that would look. Okay. Billed differently according to what type of RHC you are, because it's considered a non-RHC service, okay? So again, that 93005, which is the technical component, billed to Part B, but one is billed under the RHC ID numbers for fee schedule payment, one is billed under the hospital or parent hospital ID numbers for either fee schedule payment or at cost, depending on the type of hospital, okay? Now, I'm quickly going to talk about Medicare Advantage. There are literally 2 slides that I'm going to cover here. I like this slide from the Kaiser Family Foundation because it kind of shows you the penetration of Medicare Advantage plans going back to about 2007, projecting forward to 2033. Okay, so in 2007, there were only about 19% of eligible Medicare beneficiaries that were enrolled with a Medicare Advantage plan. Okay, in 2024, that is surpassing the 50% mark, and they're projecting that by 2033, 62% of eligible Medicare beneficiaries are going to be enrolled in a Medicare Advantage plan. The only reason I bring this up is to say if you're not paying attention to your Medicare Advantage plans and how you are being paid by your Medicare Advantage plans as an RHC, you need to, because increasingly patients are being enrolled with these MA plans. I think Mark is probably the famous one for saying that Medicare Advantage plans are not an advantage to your patients, okay? A lot of times they don't realize that they're even enrolled with a Medicare Advantage plan. And if they are, they have no idea what benefits that provides them, okay? So just be aware of that. The question comes across, I actually think it came across the Facebook group this morning. Someone asked how they're supposed to be paid by Medicare Advantage plans. And the question is, who knows? Not really. There are now almost 4,000 Medicare Advantage plans nationwide. When I did this presentation last year, it was 228 plans less than that. So it's gone up 6% in just a year, okay? That means that there are nearly 4,000 different sets of rules and contracts, okay? There is not a one-size-fits-all approach when it comes to Medicare Advantage plans. So the blanket answer you're going to get from any consultant when you ask them how you should be paid is, what does your contract say? Okay, so they're not going to automatically pay you as a rural health clinic, okay? If your language is not structured as such that it states that you will bill them as an RHC and therefore they will pay you as an RHC, that's not an automatic thing. So we encourage people to reach out early in the process when you're going through the RHC certification process to ask, hey, what language do we need to have added? Some of them will require a new contract. Some of them will just update your existing contract. It's all over the board, okay? So just know that it is important to pay attention to this. Some MA plans are going to pay you the same as regular Medicare. Some might pay you a little bit more. Some might pay you a little bit less. Hopefully this is something that we can, get some regulation about, similar to how FQHCs do, but that's still sort of to be determined at this point, okay? Here's some helpful resources. Again, you're going to get a copy of this presentation if you haven't already, so you can check those out. We can now take some questions, and then here's my contact information if anybody has any other questions they need to ask after the fact.
Okay. All right.
I made it with 4 minutes to spare.
Yes, a whole 4 minutes, and we probably have just enough questions for that, Amanda. Thank you. That was excellent as always. So we really appreciate that. Our first question here comes from Darla, and you'll be testing me if I get these right or not, because I've answered these in the little chat box. But
okay,
we'll get the right answer now.
Right.
Okay, for Amanda, can you do a follow-up and a preventive visit on the same day? Is the question.
You can. So again, Charles, I think, is going to cover preventive visits next week. You can do them both, but depending on what the preventive visit is, you're only going to get paid one all-inclusive rate. Okay. The only exception to that rule is for the IPPE, which is separately reimbursable.
Okay, I think I got that one right. Way to go, Mark.
All right.
Way to go, Amanda. Okay, we're on the same page. This is good. Okay,
right.
This one's going to be this one I'm not sure about. OBGYN visit in the morning for hot flashes, and an RHC walk-in visit in the afternoon for a sinus infection. I'm assuming this is the same person.
Okay.
How did RHCs bill these two visits on the same day? Multiple visits on the same day exception? I think what they're asking is, are they going to get paid two all-inclusive rates for this situation? Is hot flashes and sinus infection enough different that we can use a 59 or 25 to get additional payment?
So that's iffy because, if they didn't have the sinus infection when they came in the morning, but then they all of a sudden had a sinus infection in the afternoon and they came back, maybe. When I would see this situation playing out more often is if they came to the OBGYN in the morning and then let's say they got the stomach bug. Like that's a significant thing that they needed to come back for, they needed medication for, again, that's kind of iffy. I don't know that there's a great answer there. I mean, if you put 25 on there, then there's, they're probably going to pay it, but I don't know. That's kind of a gray area, to be really honest with you.
Amanda, my answer was they would probably get an ADR from Medicare to look at some more information, and they'll sort of decide. It's a 50-50 deal. So some of them won't pay,
I agree with
some
that.
of them may not.
But generally speaking, just remember that just because they see a specialist and then they see a primary care provider, those providers are operating under the same NPI number for the RHC, okay? Generally speaking, that's going to constitute one visit, okay? We're kind of splitting hairs here as to like what specific scenarios might qualify, but I agree with you, Mark.
Okay, so let's see here. And then Jill's asking, are behavioral health group therapy visits allowable as a payable encounter? The last I can find is that group visits are considered non-RHC service and are listed as such in the Medicare Benefits Manual in Chapter 13.
Right.
And she quotes it, group mental health visits do not meet the criteria for a one-on-one face-to-face encounter for an FQHC or RHC.
Yeah, group services are specifically listed as one of those examples that are considered a non-RHC service. Now, I will say several state Medicaid agencies will allow for group services from a mental health aspect.
Yeah, and what I put on there is I think that will probably change next year because of that IOP regulation there. Rural health clinics can start these things called IOPs that are open like 9 hours a week, and you have to do 3 different services. And I'm assuming you'll be doing groups in those types of settings, but that's in 2024.
Yeah, we've got to get some more guidance and details in terms of that. But yes, that's definitely possible. Just with the expansion of those services. But again, those are set to be billed under something completely different. Those are set to be, just kind of, I don't know. We just need a lot more details about what all they're going to allow us to do with that, I think, at this point.
Yeah. They definitely will not be paid under an all-inclusive rate.
Right, correct, correct.
So absolutely. Okay, and then Jillian asked for another question there. Are both VFC and private vaccines that are wasted due to expiration listed as a loss on the cost report? And I'll answer that since I'm a cost report person. They cannot be. So we will not. I will not put you on that. Since Todd wouldn't let you do cost reports,
Todd won't let me do cost reports, so don't let me answer that one.
I will jump in on that one. Okay. Let's see here. Next one is, and I think we're just going to have maybe 2 or 3 more. Do you receive? Let's see here. Do you receive a payment for any J codes, or is that included in your AIR?
It's included in your all-inclusive rate.
Yeah, I know. And the key is, do charge it because it does increase your copay, your co-insurance from the patient. You get 20% of what you charge for that. So do try to bill it incident to if you can.
Yes.
Okay.
Correct.
When reporting the mental health, mental health visit with the medical visit, what provider is reported on the UB if both are on the UB? Can you send separate UBs, one for the mental health with the CG and another one with the medical provider with the CG? That's a good question. I don't know the answer to that because
so just remember that when we're billing Medicare as an RHC, you're billing as the RHC. You're not billing as each separate provider. So they're reimbursing the RHC. Whether or not it has to be on the same claim or separate claims, I know that Charles has addressed that question before, and I think he has said that it doesn't matter, but I've not ever seen it on anything but the same claim because it's coming out of the same RHC.
Yeah, I have seen at one point Palmetto would not pay them if you put it on the same claim. You actually had
That's a good point. Some MACs have specific rules about that too.
Yeah, they have weird rules. So they would put it on a separate one. And the way the UB works is for field locator 56, you put the MPI number that you're billing under, the group MPI number. Field locator 76 is where you put the attending, the person who did the most for that particular provider. So if you for that particular patient. So if you are doing, if you have 2, I think it works just fine to have two different UBs where you could put that different person on there if that's cleaner.
Correct.
Okay. Let me see here. Okay. This thing is it's jumping around on me. Let me see if I can find where we are. City reporting. Okay. Can you do an LTC visit and a mental health visit on the same day? I don't know what an LTC is.
Long-term care.
Okay, long-term care. Okay, gotcha.
You could do like a nursing home visit and a mental health visit on the same day, if that's what we're talking about. Yes, you can do both of those. You just have to make sure the correct revenue code is assigned for that nursing home, and then you'd have the 900 revenue code for the mental health visit. Yeah, there's nothing keeping you from doing that.
Okay, perfect. Okay. How would you bill in an RHC, an office visit, and a radiology exam the same day? Do you add the 25 modifier to radiology?
No, so you're not going to add the 25 modifier. You're going to have your office visit, and then you're going to have the professional component of that radiology service that's provided on your RHC claim. Now, if it doesn't have specific CPT codes for the professional component versus the technical, that's when you're going to have the 26 modifier for the professional, and then the TC that goes on the technical component that gets split out separately.
Yeah, and the technical components, they're going to be on the 1500 form if they're in an independent. They're going to
Correct.
be on a UB04 if you're in a provider-based clinic, and it's going to be a
Yep.
bill type. Was it 851 is if CA, and then a
Something like
131 or a 141
Yep.
bill type otherwise. Okay.
Correct. Yep, you got it.
Let's see. So I know a little bit about billing.
Yeah, you know more about billing than you claim to know, Mark.
Okay. All right. I try to hide it. Okay. Let me see here. Okay. Okay. I moved the slides. Let's see here. Okay. I got to find. Okay. Radio. Okay. On the E&M visit for addressing chronic chronic conditions, then also had an annual wellness exam. Can we get paid for both a 99214 CG and a G0439?
You cannot. So the annual wellness visit specifically is not a separately billable visit if it's done on the same day as another billable encounter. And if you go to that CMS reporting requirements FAQ, it covers that scenario specifically. And in fact, the CG modifier has to go on the E&M visit and not on the annual wellness visit, regardless of which was actually the primary reason for the patient encounter that day.
Yeah, that's a frustrating thing because IPP is handled different, and the doctors really want that to change. The ones I've talked to, they're just.
Now, you should always do what's best for the patient. Like, don't separate them out onto separate days. In fact, Charles will probably cover this when he talks about preventive services, but CMS specifically says that it's not appropriate to bring that patient back on a separate day just so you can get separate reimbursement, basically.
Yeah, that's not a good thing. Okay, in our if our RHC is using the penny roll-up and the qualifying visit with the CG is on line 2, it will reflect the penny. The penny, is that okay for reimbursement?
Yeah, so that's actually a really good question that comes up a lot is, does the CG modifier line have to be like line 1 on my claim? And it does not. It's okay if it's not on line 1. The CG modifier is what's going to indicate to Medicare what amount needs to be used. Now, if it's on line 2, but then your totals are rolling up to line 1, that's a problem, okay? Because you want all of your total charges to roll to that CG modifier line wherever it ends up falling on your claim.
Next question, is it better for the patient and the office to not bill the J code to RHC, or can you send those to non-core?
If you do it in the RHC space, it should be on your RHC claim.
Yep.
And I don't know what non-core
She's saying, can we bill it to Medicare Part B? And the answer is no, you can't. You can't bill it fee for service. A lot of people want to do that. Well, we're not getting paid our J codes too, so let's just bill it to Part B. No, that's not pass go.
Now, the only thing that I will bring up is there are certain vaccines that might be covered under Part D, and that's a little bit different. But if we're specifically talking about injectable medications, so like our J code drugs, if that's done in the RHC space, it should be on the RHC claim included in your all-inclusive rate reimbursement. It's not going to get billed separately. That wouldn't be appropriate.
Okay, I've got 3 more questions, and then we're going to cut it off because we're already 8 minutes over.
Sounds good.
I know Amanda's probably got better things to do than answer our questions all day long. So we'll cut it off now. Let's see. If you charge the patient for both a procedure and a visit on the same visit, is that counted as one visit for the Medicare cost report? And okay, if that's a cost reporting question, if you charge patient both a procedure and a visit, yes, that would be one. That would be one visit there. So
yeah, generally speaking, one AIR equals one visit.
Yeah, that's right. And so when I say, a lot of people will, because for commercial insurance, you still will be using 25s. Right. Well, a lot of times when I see the 25s on there, I will not count those because I know there's an office visit somewhere for that.
Yeah.
Okay. Okay. My doc does rounds on SNF patients. Would that be revenue code 0524 or 0521?
524 is for your nursing home. 521 would be a clinic visit. So they have to come into the actual RHC to bill 521. 524 is a Part A covered stay. 525 is a non-Part A covered stay at a nursing facility.
Yeah. How is the best way for them to find that out, Amanda? Is it to, people always tell me they just have to call the nursing home and find out maybe how it
Yeah,
works? Or,
there's not really a good way to know. I mean, obviously patients can log in and they can see what all their benefits are, but there's no good way really to know except for to ask the nursing home. At least that's in my experience. Somebody else is feel free to chime in if you have a great way to do that, but that's been my experience is asking the nursing home.
Okay. Is CPT 91035 gastro blah 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 reflux test considered an RHC visit? We have a urology clinic, a urology office in our RHC.
I wouldn't know off the top of my head if that specific CPT code is on the qualifying visit list, but you just have to ask yourself, is it a medically necessary service that is face-to-face with a qualifying RHC provider? And if it meets that criteria, even if it's not on the qualifying visit list, then it might qualify for reimbursement as an RHC. You can have a urologist in the RHC space. They can have minor procedures that they do, so that's well within the possibility. I just don't know off the top of my head if that specific CPT code qualifies or not.
Yeah, I don't know it either. So yeah, I would just look at the QVL and see if it is on there. You know, QVL is not perfect. It's not been updated, but it will at least give you good guidelines on that. Okay, we got two more snuck in here, but I'm going to answer this one because it's a cost report question. If you have a medical visit and give a flu shot on the same visit, do you roll up the charges or are they separately paid? They don't go anywhere on there. If it's a flu shot, you're going to have to keep a roster and you're going to submit that to Medicare on your cost report at the end of the year. Do not bill influenza, pneumococcal, and COVID shots in a rural health clinic. You roster bill those to Medicare. So,
and I'm sure Charles will go over that in more detail when he covers preventive services next week.
Okay, let's see. Is there something? Okay, somebody, we'll get two more. All right, no more questions, people. Y'all keep sneaking them in. When seeing a patient for the annual wellness visit and also an office visit for something that you've addressed at that time, will you put the modifier 25 on that office visit?
Nope. No. So again, 25 and 59 should hardly ever be used in the RHC. Okay. If you inappropriately put it on there and get paid, Medicare is going to figure it out and you're going to have to pay that money back. But that would not be an appropriate use of modifier 25. You're still going to put both the office visit and the annual wellness visit on your claim, but you're going to have a CG modifier on the E&M that's specifically addressed in that CMS reporting requirements FAQ, and you're going to get an all-inclusive rate payment at 80% less 2%.
Okay, one last one. Now, I don't know the answer to this one either. This one here. As a primary care physician, can you bill a mental health charge if the patient comes in for mental health or behavioral health issues?
A primary care provider can see a patient for mental health issues. So like think depression, anxiety, things like that. Our RHC primary care providers do see patients for those things, okay? Those generally only fall under the level of an E&M visit, okay? They're not falling under one of our mental health CPT codes like psychotherapy, psychoanalysis, or anything like that, okay? Now, you can also have a primary care provider who has been trained to provide mental health services that might still be able to bill those mental health codes, but they do have to have specific training in that mental health space to be able to do that, okay?
Okay, perfect. Okay, and then I'm going to ask a question, and this is a really super hard one because I asked this question to our our little core brain group, and none of us. I heard cricket. So what about so what is that? Ozempic and Zepbound and all that? When people are doing weight loss, for that, is there a good way for these RHCs to do that? Because the cost report Brain Trust came up with crickets on trying to figure out how to deal with that.
You know, I don't even know what people are billing for that particular service. I mean, is it something that a provider is required to give, or is it something that's being given by, you know, your clinical staff? So I don't know, to be honest. I'd have to do a little more research.
It's all over the board on what people are doing, how to do it. I don't think anybody's really figured out how to handle it yet from a cost report.
Yeah. Well, because it's a pretty expensive medication, if I understand as well. So I also can see where you wouldn't want to do it in the RHC just because even if it was a reimbursable service, and I don't know that off the top of my head, That's
Yeah.
pretty expensive medication, and you're only getting a limited reimbursement for it. So just kind of think about that. Like, it may not be the best service to provide in an RHC space.
That's what I was sort of thinking. Okay, Amanda, thank you for staying over an extra 15 minutes. I know our people will appreciate it very much. We appreciate you. I hope you get feeling better.
Thank you.
And thank you, everybody, for joining us today. We'll get the recording out to you, and we'll get the slides out and all that stuff. So thank you, and then come back.
Thanks, everybody.
On Thursday, we'll have Patty Harper. We'll have another great speaker. So this is wonderful. All right, thank you. Bye, everybody.